All right, good evening. Good evening, everyone. For those of you who don't know me, I'm Trevor McMillan. I have the great privilege of being the Vice-Chancellor here at Keele. And that privilege very much extends to being able to host as many of these inaugural lectures as I possibly can. And as I always say on these occasions, this is a fantastic opportunity for the university to show off our talent, to show off the research we do, and how special many of the people are that work, working in the university. Inaugural lectures are one of those things that Keele has kept going. We think they're important. Many other universities have stopped doing these, and I think that's a great shame, because it's an opportunity for our new professors to show us what they do in terms of research. I have to say, they're quite difficult lectures to organise. It's a little while since I did mine, but we were discussing with Joe. They are difficult. We've got a broad audience here. Some of you will know exactly the detail behind a lot of things that Joe's talking about. Some of you, it will be very much a general approach, and you'll get the general story, but maybe not the details. But it's also an opportunity for family members, for friends to come, and it's a special delight to welcome Joe's family here this evening to enjoy the lecture. Again, I was saying to Joe, these lectures can take an awful lot of different formats, and she's declined to compare with the last one we actually did, which was one of our philosophers who actually sang his inaugural lecture, accompanied by a 4-piece jazz band, such as the life of philosophers. So we're not getting that from Joe this evening. Jo received her first degree in medicine from Bristol University. She then did her general practice training and got her MRC GP after that training. She then went on to do a master's and a PhD in Manchester before moving to Keele in 2011. And we appointed her here first as a senior lecturer in primary care as part of our Institute of Primary Care and Health Sciences. Jo was promoted to Professor of General Practice in 2017, and it's there where she continues her research, but also leads the general practice medical curriculum. And that is an area where Keele seriously has a very, very strong national and indeed international reputation as part of our contribution, not only to medical education, but subsequently the medical workforce. And I have to say that because we've got the Chief Executive of Health Education England in the audience this evening. So with colleagues, Jo has twice been awarded the RCGP Research Paper of the Year, and indeed last year received the Royal College John Fry Award for promoting the discipline of general practice through research and publishing. Jo's research area is centred around engaging patients in their healthcare, shared decision-making and health literacy, and so it's with great pleasure that I ask Professor Jo Protheroe to present her inaugural lecture this evening. Thank you.
Thank you very much. Thank you for that lovely introduction, Trevor, and thank you all for coming this evening. I'm going to talk this evening about engaging patients in their healthcare, from shared decision-making to health literacy. What I'm going to focus on is how research and policy has changed over time and how it's impacting on patients' care, and hopefully my contribution to that as well. So I started my academic career, as Trevor mentioned, in Bristol, and I'd just qualified as a GP, and I thought I wasn't quite ready to settle into a partnership. So I approached Professor Debbie Sharp at the University of Bristol and asked her about the possibility of trying some research. She introduced me to Tom Fahey, who was then a senior lecturer in general practice, now a professor in general practice in the University of Dublin. Trinity University, sorry. And he was researching in the area of shared decision-making. Shared decision-making at this time, which was the late 1990s, was something of a novel concept. It's not the widespread practice that we know it for and accept it as today. So Debbie and Tom supported me to apply for a Wellcome Trust Research Training Fellowship, and I started my first project on patient preferences and shared decision making. So this was looking at the impact of patient preferences on the treatment of atrial fibrillation. Atrial fibrillation is an irregular heartbeat, and the main treatment then, and indeed still now, is about not focusing so much on the irregular heartbeat, but on focusing on reducing the risk of stroke. If you have an irregular heartbeat, you are at an increased risk of stroke because your heart beating irregularly can sometimes throw off blood clots. So this treatment that we were talking about here and the patient choice in it was about the treatment whether or not to take blood thinning tablets, anticoagulation or warfarin tablets in order to reduce the risk of stroke. And that's actually a more complex decision than maybe it first sounds. If you think about it as a patient who's been told they've got a heart condition, to then be told you need to take a tablet that isn't treating the heart condition that you've got and isn't going to make you feel better by taking the tablet. It's a tablet that might reduce the risk of something that might possibly happen in the future. Not only that, you're suddenly being told you have to take a tablet every single day, and you have to have regular blood tests to adjust the dose so that the dose is right. And this tablet will have side effects, which might be simply a bit more tendency to bruise or the odd nosebleed, but might be a serious bleed. It's a lot to decide about the pros and cons of taking a tablet to reduce something that may or may not happen in the future. So this study was to try and do using individualized decision analysis to try and quantify patients' preference for taking that treatment and then compare that with the treatment that they were actually receiving from their cardiologist or their GP, and then also compare it with the treatment that the guidelines said that they should be receiving. So 3 groups: what the patient would like, what they're actually getting, and what the guidelines say they should be getting. So after that long preamble, you'll perhaps not be surprised to hear that actually what we found was that none of those 3 groups matched. What the patient was actually getting didn't match. What the patient was actually wanting didn't match. What the patient was actually getting didn't match what the guidance is saying that they should be having. So the conclusion of this study was that especially in treatments like this, or treatment decisions like this, where there's no right or wrong answer, that patient's preference was really important. So, as I said to you, we were lucky with the timing because shared decision making was the new lad on the block or whatever, the new thing, and it got published in the BMJ and was also awarded the Royal College of GPs Research Paper of the Year in 2000. Not only that, patient preferences have been adopted into guidance, and this is the latest NICE guidance, and patient preference about decisions about treatment for atrial fibrillation is still in their guidelines. So that was a good start. Having that publication and winning the prize certainly helped me when I applied for my next research fellowship, a Medical Research Council training fellowship, 4-year fellowship to undertake a master's and a PhD. But at this time, my husband had just got his consultant job in Salford, so we moved up to Manchester from Bristol, and this is where I met Pete Bower, who became my PhD supervisor, now Professor of Health Sciences in Manchester. It's also where I started at West Gorton Medical Centre, which is a practice in inner city Manchester, in quite a socioeconomically deprived area of Manchester. I started as a salaried GP there and worked there for just over 14 years and ended up as a partner in the last few years. These were the partners there when I started, some of who I'm pleased to say have joined us in the audience. So the practice looked like that all the time I was working there. They've got a lovely new building now. I don't think it's related to me leaving. Anyway, whilst I was there, my PhD was still looking at shared decision-making, but looking at enhancing decision-making using computerized decision aid in patients with menorrhagia, heavy menstrual bleeding. So the study itself was a success, using the decision aid, involving patients in decisions about which treatment to have for their heavy menstrual bleeding. it worked. Using the decision aid in this randomised control trial, patients who had the intervention were more involved in decisions about their treatment. They improved their knowledge, they improved their quality of life. That was straightforward. What was more astonishing in this trial was that we started to get handwritten thank you notes and letters from patients who had been involved in the trial. And that's quite unusual. Researchers in the audience will know that we have enough trouble recruiting participants to our trial. It's quite unusual to get handwritten notes saying, thank you so much for involving me in your study. Since I've been in your study, I've been able to go back to my doctor and tell him exactly what treatment I want for my period problems. I've been able to feel that I can talk to my gynecologist now. That was quite remarkable. And this was also backed up by the qualitative interview project that we were doing alongside the trial. And we could see that whilst overall all the women involved in the trial appreciated being involved in the trial and enjoyed using the decision aid, it was more important to some people than others. For some women, it was one of many options that they had to help make a decision about what treatment to go for. They were already talking to their GP or their gynecologist. They were already talking to their family and friends, some of whom were health professionals. They could already look things up online or read patient information leaflets. So to them, the decision aid was great. Yes, they enjoyed using it, but it was one of many things that they had. To another group of women, it appeared to them to be the first time they had understood that they had a choice about what treatments they could have. It was the first time that they'd received information that they could understand and they could use to make a choice about what treatment. So this was really something quite different. And that, alongside working in West Gorton Medical Centre with the lower socioeconomic patients we had there, gave me my light bulb moment. That really, we're starting in the wrong place to start with shared decision making. We need to take a step back behind shared decision making and think about what we need for our patients to be able to engage in shared decision making, to involve them in patient decisions about their care. They need to be able to access, understand and use information to be involved in that decision, to realise that they can have a choice in their healthcare. So that was where I came upon the concept of health literacy. At that time, in the early 2000s, in the UK, health literacy was a relatively unknown concept. This was the definition from the United States of America, from the Institute of Medicine, that health literacy is defined as the degree to which individuals have the capacity to obtain, process and understand basic health information and services needed to make health decisions. Eureka, that's exactly what I'd been thinking. That's what I'm talking about, health literacy. So I carried on postdoctoral, my next research fellowship, researching in the area of health literacy. But we really struggled to get publications to use the term health literacy when journal editors and funders in the UK had never come across the term of health literacy. And so we started with terms like patient engagement, patient participation, then we'd link participation to the words health literacy, and then eventually we got going with health literacy. But as you'll see from this graph about health literacy as a research topic from 2000 right up to when the graph was taken in the middle of 2017, publications have risen sharply as health literacy has become a more common topic. So this was about when I had my next piece of good fortune and good luck. This was when I met Jill Rowlands at an academic primary care, Society of Academic Primary Care meeting. And I met Jill and she was already interested in health literacy and she already had got a small amount of funding from the then Department of Health. And we set up between us a special interest group at the Society of Academic Primary Care and then moved on to set up Health Literacy UK, which was an online website. I think initially, Jill, it probably felt like the only members were you and I, but now we have over 800 active members and we're running regular seminars and conferences through this website. So that was a great meeting and that's the start of much more health literacy research, and because of all those seminars, getting academics together and really developing a push for more research in health literacy. So the research is now really coming out in the UK and across the world. We were getting hundreds or thousands of studies that were showing that the health literacy had a serious impact on health and outcomes. So people with low health literacy were less likely to use preventative services, the evidence was showing, more likely to have delayed diagnoses, less likely to understand their medical condition, less likely to be able to adhere to medical instructions, and less likely to be able to adhere to self-management instructions or have self-management skills. People with low health literacy were at an increased risk of hospitalisation. They had poorer physical and mental health and an increased risk of mortality. And this was interesting because this increased risk of mortality remained strong even if you took into account baseline health, risk factors such as smoking and alcohol and socioeconomic status. You're still more likely to die if you had low health literacy than not. At the same time, with the research going on, that definition was changing a little bit from the Institute of Medicine initial definition about health literacy being all about an individual skill to recognising that it's more about the balance between the skills of the patient, family, community, and the environment in which they live, that balance between the two, and the health systems, education systems, and social care systems. I'm just going to show a 1-minute clip from the National Adult Literacy Agency in Ireland, which I think really encapsulates health literacy a bit better than all these definitions and words.
No idea what prognosis is.
Prognosis? I've never heard of prognosis.
Prognosis means the diagnosis or the outcome, I think. I'm not really sure now.
Chronic condition, isn't that when you have like a real chronic like pain, like severe condition?
Chronic condition. It's where something is severe.
Doctors and pharmacists use really, really confusing words. They're too long and big.
I went to a doctor to talk about my back pain. He said something about tendons and stuff ripped on my back, and I didn't know what he was talking about.
And had to pull up my own consultant recently for his lack of ability to explain in clear language, not infantile language because I have some intelligence, but clear language about what exactly they're on about. So I would say it's one of the biggest failings the profession have, both pharmacists and medical people.
So I think that really explains it nicely, and something that we as health professionals and health researchers perhaps forget is that we've spent all our schooling doing science and then gone to university and learned how to be a health professional. We've learned the equivalent of a whole modern foreign language. We've learned a lot of new words, and we forget to translate them back into what the Americans call living room language when we're talking to our patients or clients. We use words in a different way, like the example of chronic in that film clip. We use it in a completely different way in healthcare to the way it's used by normal people living normal lives, not healthcare professionals. Health literacy is so context and content specific. It's like explaining, you know, I'm a GP and a health researcher, so I'm very comfortable to sit down and talk to anybody about health or health research. But if I sit down with a financial advisor and try and talk to them about superannuation or tax or pensions, then I feel out of my depth. I start to get that sweaty palm, slightly, anxious. You think, I know it's really important, but I can't quite understand it. And that's how it is for some people with health. I would say I have quite limited financial literacy in the same way that some people might have limited health literacy. And it's not just about being able to read and write. So moving back to the story, this is when I had my next stroke of good luck and good fortune. It was when I met Christian Mallon at another academic primary care meeting, and he convinced me to come and join Keele, come and apply to Keele. So I did, and in 2011, as Trevor already mentioned, I applied, was appointed as senior lecturer in primary care in the Research Institute. And Christian Mallon and Elaine Hay, who was then director of the Research Institute, were very supportive and could see that health literacy had a very important place to play in translational research, in some of their, renowned reputation for musculoskeletal research. They could see how health literacy could add to that, and so invited me to not only join ongoing projects, but to continue researching health literacy alongside this. So many of the research groups in primary care soon got fed up of me saying, there's a health literacy aspect to this. I think some of them recognised that they got fed up. But I think hopefully I managed to get some converts in primary care as well. What was holding us back with health literacy research in England was this notion of how big is the problem. We've got lots of evidence now that says there is a problem. We know that it makes health worse and it has an effect on mortality. We've got all the research evidence saying that. But if you want to convince funders and policymakers that it's an important problem, they need to know how big is the problem. Is it just affecting a few people or is it affecting a lot? So we were struggling with that. England didn't have a national survey of health literacy like many of the other countries. So this is where we had our next breakthrough. Jill led on a project that she and I both ran where we looked at the complexity of health information. So when I talk about health information, I mean very broadly health information. So the information that you would see on the side of a bottle of children's paracetamol, the information that you would get to fit a child car seat in the back of the car, information that would pop through the letterbox for older people for screening for fecal occult bloods, for colorectal cancer screening. A broad variety of health information that is put out there for people to look after themselves. And we took this information to external experts from the English National Qualifications Framework and asked them to look at that information and tell us how complex it was, how literate and numerate a person had to be to understand and use that information. And then we compared the literacy and numeracy complexity of the information that we as an English nation were putting out to help our population. We compared it with the skills of the English working age population from a recent Skill for Life survey in 2011, which looked at the literacy, numeracy and ICT skills of working age adults. Again, you'll perhaps not be surprised to hear there's a mismatch between the population health literacy and the complexity of health materials that we were putting out there in our waiting rooms, in our hospitals, in the chemists, all over the place. Perhaps you'll be staggered to hear how big the mismatch was, that health information is too complex for 43% of people aged between 16 and 65. And if that information, like the information on the side of a bottle of Calpol, where it says so many mils of medicine per kilo of child, if that information contains maths, it's too complex for 61% of the population. We have over 34 million adults in England of working age. So this means that between 15 and 21 million people of working age, 15 and 21 million people, may not be able to understand and use the information they need to look after their health. So this project was something of a game changer for Jill and I. We were able to present these findings to the House of Commons. We were interviewed by local and national media, on the radio, in the newspapers. That's me on breakfast television. It really did make a difference. It caught the media's attention. At the same time as all this was going on, I was starting to have a very fruitful relationship with Stoke-on-Trent Public Health. I was working with Judy Kurth and Linda Clark from Stoke-on-Trent Public Health, and we were looking at trying to design something to measure the health literacy of our population in Stoke-on-Trent. We know that the health of people in Stoke-on-Trent is generally worse than the England average. We know that deprivation is higher than average and almost a third of children live in poverty. Education attainment is lower than the England average and life expectancy for men and women is lower than the England average. So we weren't really expecting health literacy to be higher than the England average. Well, what we designed and rolled out a survey face-to-face of randomly selected adults in Stoke-on-Trent to measure health literacy using something called the newest vital sign. The newest vital sign is designed around an ice cream label, the sort of food label you would see on the side of a tub of ice cream in the supermarket, where it's got ingredients and calorie count, that sort of thing. And the newest vital sign is 6 questions associated with a food label. The nice thing about this test of health literacy is that it's something that patients recognise, or participants in studies recognise as being relevant. It's something they would expect to do when they go shopping for the family, to look at food labels and decide whether to buy that item. So this is an example of one of the questions Imagine that you're allergic to the following substances: penicillin, peanuts, latex gloves and bee stings. Is it safe for you to eat this ice cream? No, absolutely right. It's not safe. It's got peanut oil in it. So the questions were like that, and the other questions included things like, if you had a portion of ice cream, how many calories are you eating? So not complex questions. But we found in Stoke-on-Trent that health literacy measured using the newest vital sign, 52% of our adult population had less than adequate health literacy, over half. And poor health literacy is significantly associated with being older, having poorer health in the first place, lack of access to the internet, living in deprived areas. Perhaps those very people who need good health information. So, armed with this national and local data, we started to hold a series of town hall meetings in Stoke-on-Trent to present the local and national data to. They were open meetings, but we invited a lot of professionals. We invited healthcare professionals, social care professionals, teachers, PE teachers, football coaches, you name it, they were all invited. And we presented to them the findings of the health literacy surveys, both national and local, and what health literacy meant. And we engaged with them to develop a Stoke-on-Trent health literacy strategy to make Stoke-on-Trent a health literate city. So that was the aim of these. I think we had 4 town hall meetings over a series of a number of weeks. And so the first meeting was to develop the strategy, and then following meetings, we also looked at seeing what these professionals could do in their daily working lives to increase health literacy and to take account of health literacy and increase health literacy in the clients and patients that they were working with. And in addition to that, they also gave us some suggestions what Stoke-on-Trent Public Health and City Council could do to help improve the health literacy of its local population. A health literacy steering group was set up in Stoke-on-Trent, which is chaired by Mike Oliver, who's here this evening. And it's still going now, and lots of really exciting projects have come out of this work, which I'll talk a little bit about a bit later on. And I'm still a member of that steering group, so it's great work that we've been doing. So this work, both the work that Health Literacy UK were doing and the work that Stoke-on-Trent Public Health is doing, was starting to make an impact, was starting to get picked up by not yet policy documents, but documents about policy. So this was the all-party parliamentary group report on the 5-year forward, and they recognised the pioneering survey in the city of Stoke-on-Trent's public health, and also mentioned some of the work from Health Literacy UK. So they recognised that health literacy was important, as did Public Health England when they produced this report on action in health inequalities, citing our work again, improving health literacy to reduce health inequalities. And they recognised that efforts to improve health literacy had a range of benefits: increasing knowledge, building resilience, encouraging positive lifestyle change, empowering people to effectively manage their health, and decreasing the burden on health and social care resources. So now we're getting policy involved. That in the top right-hand corner, that's Scotland, NHS Scotland's second health literacy policy. Northern Ireland are including it in their Healthy Cities policies. This one here is Wales, Fair Outcomes for All, a health literacy policy for NHS Wales. And NHS England have also included it in various aspects of their policy. That is the shared decision-making website. NHS England appointed myself and Jill as the first health literacy clinical advisors to the NHS. I'm a member of NHS England's Health Literacy Collaborative, and it's been included in the shared decision-making policy that I mentioned. It's also included in they have specific health literacy guidelines on their new digital website, and it's included in the NHS long-term plan and universal personalised care. So where are we now? We've moved from just simply defining health literacy and identifying health literacy. We've recognised the importance of health literacy, and we've recognised the effect on health and mortality. We've identified the size of the problem, and we've engaged with the research and policy communities. What we need to do next? Well, WHO have moved on in their definitions of health literacy as well, and recognised it as a social determinant of health. And they've broadened their definition up from that initial definition I showed you from the Institute of Medicine, which was all about the individual skills, the individual having skills or not of being able to access and use information, to now recognizing that it's a balance between those individual skills, personal characteristics, and the social resources that are needed for individuals and communities to be able to access, use, and understand information and services to make decisions about health. So what we need to do next is think about that balance between the skills and the demands and complexity, and really focus on intervention, design and implementation, on building skills in individuals and communities, increasing our health literacy assets, and at the same time reducing system complexity and service demand and reducing the risk of low health literacy. So what we as health professionals can do is, health and social care professionals, we can raise awareness amongst our colleagues and our training health and social care professionals. We can use simplified texts and pictures in written communications, taking a universal precaution approach. So not just trying to identify people who we think might have low health literacy, but making our written communication simple and easy to use for everybody. We can place an emphasis on building knowledge and cognitive skills when we are having dealings with patients and clients. So using health literacy communication techniques such as teach-back. Teach-back is quite a simple technique where you take the onus of communication onto the health professional that is communicating the message, rather than leaving it with the patient or the client to understand. So if I'd seen a patient and given them a new diagnosis of diabetes and then given a lot of information about diabetes, instead of just at the end saying, do you have any questions? Which, if you've just given a whole load of new information, the patient is quite likely to be overwhelmed and may very likely just say, no, that's fine. But it's not really informative. So a much better way, the using teach-back, the health literacy way of doing that, is to say to the patient, I've just given you a lot of information about diabetes this morning, and I just want to make sure that I've covered everything, that I've said everything I want to say. So can you just tell me back what you think are the main messages, and I can see if I've missed something. So you're taking the ownership of having communicated well, rather than expecting the patient to have ownership of understanding well. It doesn't take any longer, and in fact, it saves time in the long run, because if you then get the message back that the patient you've just met has understood everything about getting her feet checked and going regularly to the optician and seeing the nurse about her diet, but has misunderstood what you've just said to her about her metformin dose or the tablet that she's got to take, if you can then clear that misunderstanding up straight away and save problems further down the line. Other cognitive skills techniques are an initiative called It's Okay to Ask, which I'll come back to in a minute. It's come out of the Stoke-on-Trent Health Literacy Strategy. We should also consider the organisation of our health services, our built environment, signage, navigation, increasingly complex referral systems which involve patients having to phone numbers and say passwords and go online. We're not making it any easier. Signage in hospitals should be signed as X-ray, signed for the patient, not the health people that work in the hospital. X-ray, not radiology. Eye department, not ophthalmology. So this is the It's Okay to Ask. This is one of the initiatives that came out of the Stoke-on-Trent public health work that we did early on. And it's been taking place at University Hospitals of North Midlands, one of our primary teaching hospital centres, teaching university centres with the medical school. And they're using a campaign to try and encourage patients to ask questions about their health and their healthcare and what's happening at the hospital. And people wear badges, the leaflets are out, there are posters, and everybody, there is an encouraging question atmosphere to try and focus on building skills in the patient and also reducing the complexity. So doing both of those things, reducing the risk and building the assets in the patients. This has been, I think this has been adopted by NHS England now, and it's not only in our hospitals, it's in our GP surgeries locally as well. Another project that came out of the Stoke-on-Trent work was Stoke Speaks Out, which is a multi-agency run by speech therapists, where we recognise that some of our preschool children had lower vocabulary than the English average. So using health literacy knowledge and health literacy language, we developed, or Stoke Speaks Out developed, health literacy resources, which were essentially dress-up boxes, really. Dress-up boxes for children to do what they like to do most and dress up and play it at health, but with a vocabulary crib sheet so that the nursery nurse or the childminder could inform that during play and build the vocabulary of the child. We have 4 resource boxes: going to the dentist, going to the hospital, going to the doctors, and healthy eating. And sometimes we'd have the side effect of improving the health literacy of the parent or carer that was coming along with the child. We've also arranged some Stoke Health Literacy Training and Awareness course delivered by Community Health and Learning Foundation, where GPs, practice personnel, nurses, health visitors, pharmacists, dentists, teachers, social workers, local authority planners, fire service professionals came along to courses and learnt about health literacy, what it is, why it's important, how it can impact in practice, and more importantly, were given tools to help them to use in those situations. We know from research evidence that improving health literacy works. We know from the research evidence that if you improve health literacy, you will improve medication use. You will improve self-management of conditions, reduce reported disease severity, reduce unplanned emergency department visits, and reduce hospital use. We know from Public Health England that if we improve health literacy, this is also going to improve health inequalities. They state that the available evidence suggests that strategies to improve health literacy are important empowerment tools which have the potential to reduce health inequalities. Because, as we pointed out with that Stoke-on-Trent survey at the beginning, the most vulnerable and disadvantaged people in society are at risk of limited health literacy and known to have the poorest health outcomes. So this is my vision. This is what I would like to see, that health literacy is right at the heart of all of patient-centred healthcare. And I think that this is becoming even more important, not less, because health is getting a lot more complex. We've got genomics and proteomics, and it's going to be a lot more complex to explain that and understand that when you're talking about risks of things happening in the future. I think health literacy is going to become even more important and we need to take it much more seriously. So in my new role as Professor of General Practice in the medical school, what I really hope is that all graduating medical students from Keele Medical School will be aware of and know how to support patient health literacy. And I also hope that our partner university hospital trusts will be able to embed and evaluate the benefit of health literacy practices in routine patient care. And so hopefully we'll see less of this happening.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you have to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
I'd just like to finish with a thank you to everybody that's helped me get to this place, and that's my mum and dad in the middle there who can't be with us this evening. And then finally, most importantly, thank you to, sorry, look at that, I've been fine all the way through. Thank you to Richard, Gwyl and Lizzie, my family. Thank you very much.